morning and welcome everyone. I, Dr. Ritika Dhiman, on behalf of Voice of Healthcare, welcomes all the speakers and the viewers who have joined in for today's discussion. On the occasion of World Lymphoma Awareness Month, Voice of Healthcare and AstraZeneca has taken an initiative to bring together the experts and speakers for this resourceful discussion today, which aims to understand the journey of lymphoma and leukemia. With this discussion, we should also dive into understanding the stages, facts, and myths around lymphoma and leukemia, along with how a proper diagnosis can aid with better patient outcomes. We will also be having the honor of having the direct patient voices with us, Lymphoma Warrior, with the journey of conquering the disease, and much more. I would like to commence this session by introducing our eminent speakers. Dr. Kishore Kumar. He is a senior hemato-oncologist and bone marrow transplant physician, MIOT International. Welcome, Dr. Kumar. Dr. Amrita Ramaswamy. She is a consultant hemato-oncology and stem cell transplantation, Artemis Hospital. Welcome, Dr. Ramaswamy. Dr. 𝗟𝗬𝗠𝗏𝗂𝗍𝗓, Professor and Head, Department of Hematology, NRS Medical College and Hospital, Kolkata. He will be joining us in a bit. Miss Jyotsna Govill, Chairman, Indian Cancer Society, New Delhi. Welcome, Miss Govill. Miss Suchita Nikhil Varadkar. She is our patient voice for today. Welcome, Miss Varadkar. Dr. 𝗍𝗶𝗊𝗚, he is a senior consultant, Department of Hematology and PMT, Lilavati Hospital and Research Center, Mumbai. Dr. Abhay will join us in a later part of the session. Dr. Anamika Baklewal, consultant hematologist and bone marrow transplant specialist, Venkateshwar Hospital, Delhi. She will also moderate today's session. Welcome, Dr. Baklewal. So without further ado, I will hand this session over to Dr. Anamika. Dr. Anamika, I think you are on a mute. You are on mute. Can you please unmute your?
Can you hear me
Yes,
now?
yes.
Hi, so good evening, everyone. I'm so happy to moderate this session amongst all you eminent speakers and panelists. So we'll begin our session. So my first question is directed to you, Dr. Kishore, sir. So can you just enlighten us a little bit about the common type of leukemias and lymphomas?
Uh, Thank you, Dr. Anamika, and thank you, Voice of Healthcare, for giving us this opportunity. This is World Lymphoma Month. I think we are highly targeted and oriented towards discussing this type of blood cancers, that is leukemias and lymphomas. To give an overview of things to the people who are watching it, I should say, being a hematologist, blood is one dynamic organ. I will call it as an organ. Everybody thinks it to be more of a liquid thing, but actually it's a very dynamic organ. If I want to be a bit more philosophical, like how we say nothing is permanent in life, it very much gets on to the blood system, because whatever the things we are seeing in blood, like the red blood cells, white blood cells, or platelets, which make the blood actually, they all have a limited lifespan, and throughout our life, every day some cell or other will be continuously dying. So, and it is such a dynamic organ that the dead cells are immediately replaced by the production factory, which is our bone marrow, which is the brownish substance we all can see, which is present in between our bones, I should say. So whenever there is something going wrong with this production factory, so at a particular phase, there should be destruction and continuous replacement of these blood cells which are dying. Suppose something gets into a trouble. The trouble may be due to multiple reasons, which the rest of my speakers will be enlightening upon. If something goes wrong in the bone marrow, suddenly the cells go into kind of haywire and they start getting produced more. So anything that is in excess of what is needed in the body, we tend to call it as cancer. So naturally, when these blood producing cells or blood cells tend to become more than what is needed, it may be red blood cells, it may be white blood cells, or it may be their precursor cells, which are the forefathers of them, which are there in the bone marrow. If they're going to go very high in number compared to what normal is, we tend to call them, in simple terminology, blood cancers. Many times, if it is kind of highly restricted to the blood, the liquid part alone, we tend to call them as leukemias. If it goes to the different solid parts of the body, like what we call as lymph glands or the liver or spleen, where commonly these cells tend to kind of stage or station themselves to do their function. Those type of cancers we tend to call them as lymphomas. Many times, depending upon how fast the patient is presenting to us, how bad the patient is presenting to us, and how fast the cancer is progressing, we give them names like acute leukemias or lymphomas and chronic leukemias, or in one way I can say lymphomas also. It's more on how fast the cancer is going. So in acute leukemias, there are multiple types, subtypes, which I'm not going to any details. So like acute myeloids, lymphoid, etc. And in chronic also, we have more of this chronic myeloid and lymphoid leukemias. When it comes to lymphoma, again, I can divide it this way: how fast the cancer grows. We have certain very, very slow growing cancers in lymphomas. Sometimes most of the so-called Hodgkins may be presenting that way. And sometimes we have really very aggressive lymphomas called it's like Burkitt's lymphoma, which grows at a phase in front of your eyes. We can see it growing. So these are all the common types of leukemias and lymphomas which we see in our country. Thank you, Anamika.
Thank you so much, sir. So, taking this talk forward, Dr. Abhay sir has joined us. Good evening, sir. So, my next
Good
question is
evening.
directed to you. How common is leukemia and lymphoma in India?
Oh, first of all, thank you, Dr. Anamika, and your platform for an opportunity. I think the voice of healthcare reaches out to a large number of people. So thank you for doing what you're doing. I wish I could answer your question in all honesty. If you're talking of how many cases of lymphoma and leukemia we have in our country, I think it's going to be hard to answer, because we need a very vibrant centralized registry to be able to give you that answer. I'll answer this quickly in two parts. I can give you some numbers based on what has been published. So as of 2 years ago, we had probably more non-Hodgkin's lymphoma than Hodgkin's lymphoma. And we are looking at probably 4 times more non-Hodgkin's lymphoma, almost 41,000 patients. And Hodgkin's lymphoma was about 11,000 odd patients that were registered or documented. We don't know how many are not documented. Now, the reason for that is probably that we don't have vibrant facilities for the diagnosis or pickup of patients who've got lymphoma, because unfortunately in our country, still many patients with lymph nodes are treated as tuberculosis. And it's when tuberculosis treatment fails, then more tertiary centers or secondary or tertiary centers are involved. And then a biopsy, a formal biopsy is done of the lymph node to make a diagnosis of lymphoma. And sometimes it has to be referred out to a tertiary center, which is not lymphoma specific, but has the talent to diagnose lymphoma through what we call as immunohistochemistry. That means we actually have to have special stains done on the lymph node in order to not only tell you whether it's lymphoma or not, it has to tell you the subtype of the lymphoma. And in cities, we've reached a stage where we can go into details of which type of lymphoma, Hodgkin's versus non-Hodgkin's, and the different subcategories of each type. But reaching such places is a problem. So I don't know how many are being missed outside, and therefore I don't know what is the true number of lymphoma. And as far as leukemias, it's hard to tell you any numbers, but we see a large number of leukemias in our country. Unfortunately, many of the leukemics don't reach the stage of diagnosis because as part of their presentation, especially acute leukemia, they might end up in sepsis, and they may even die even before they are diagnosed or immediately after they are diagnosed. So it's hard to give you specific numbers.
Thank you, sir. I absolutely agree with you. That's absolutely correct. So, moving forward, my next question is for Dr. Amrita ma'am. So, can you just enlighten the audience and tell them the difference between Hodgkin's and non-Hodgkin's lymphoma and their varied or similar presentations?
Thank you, Dr. Anamika, for that question. So when this, I was thinking this is quite scientific for this forum, this particular question, differences between Hodgkin's and non-Hodgkin's. So I'll try to make it as less scientific as possible. So, as Dr. Kishore has already said, lymphomas have their origin in certain cells in the blood called lymphocytes, and we have normal T lymphocytes and normal B lymphocytes. And lymphomas that originate from B lymphocytes are called B lymphomas, and the ones that originate from T lymphocytes are called T lymphomas. Now, Hodgkin's disease originates only from the B lymphocyte. So it is a B, its cell of origin is a B lymphocyte, whereas non-Hodgkin's lymphomas, they can be either B lymphocyte in origin or T lymphocyte in origin, and sometimes you even have origins in natural killer cells. Apart from this, the only differentiating feature is pathologic. The presence of a particular kind of cell called a 𝗲𝗓𝗏 cell or its variant is what distinguishes Hodgkin's lymphoma from a non-Hodgkin's lymphoma. So this is entirely up to the pathologist to tell us whether it is a Hodgkin's lymphoma or a non-Hodgkin's lymphoma. As Dr. Abhay rightly pointed out, immunohistochemistry or IHC helps us in differentiating between a Hodgkin's and a non-Hodgkin's. And amidst or amongst the non-Hodgkin's lymphomas also, we have various which are slow growing or indolent, and then we have an intermediate category, and then we have the highly aggressive Burkitt's lymphoma and lymphoblastic lymphomas. This is based on the biology, how you differentiate Hodgkin's and a non-Hodgkin's. Now, coming to the clinical behavior, can we clinically differentiate between a Hodgkin's and a non-Hodgkin's? There are certain clues which might kind of tell us that this is Hodgkin's lymphoma and this is non-Hodgkin's lymphoma. But coming to the symptoms are pretty much the same, be it a Hodgkin's or be it a non-Hodgkin's. People can come to you with fever, they can come to you with weight loss, they can come to you with lymph node swellings, they can come to you with loss of appetite. So these are so-called constitutional symptoms or B symptoms, and they are pretty much common to both categories of lymphoma, be it Hodgkin's or non-Hodgkin's. Apart from that, Hodgkin's tends to be seen in younger individuals. Some people say there is a bimodal distribution. You see a peak in younger age and then you see a peak later on. Non-Hodgkin's lymphoma generally tends to be diagnosed later in life. Apart from that, Hodgkin's, the classically described differentiating feature between a Hodgkin's and a non-Hodgkin's is the kind of spread that a Hodgkin's lymphoma follows. So Hodgkin's lymphoma is supposed to spread in a very orderly manner from one lymph node group to another. So there is a good chance that we may pick up Hodgkin's in stage 1 or stage 2 when the patient has just one group of lymph nodes involved in the body. Whereas non-Hodgkin's lymphoma tends to be multicentric in involvement. By multicentric, what I mean is involvement of multiple lymph node groups simultaneously. So this is kind of certain clinical differences between Hodgkin's and non-Hodgkin's. Both lymphomas, be it stage 4 or stage 1, they have good modalities of treatment, and both lymphomas usually tend to have a fair or a generally good prognosis. Have we... So I'm sorry, can everybody hear me? We seem to have...
No, we can hear you, Dr. Amrita. We can hear you, but I don't know where is Dr. Anamika.
I think we have lost Dr. Anamika. Yeah. Dr. Anamika?
Yeah, I'm so sorry. I think my connection is very poor.
So I finished answering the
Thank
question.
you so much. No, I did hear most of it. Thank you so much, Dr. Amrita. So Dr. Tufan has joined us. Hi, sir. Can you hear me?
Yes. Can you able to hear me? Can you able to hear me?
Yes, sir. We can hear you. Yes, we can hear you.
Okay.
Yeah, so my next question is directed towards you, sir. So what are the most common causes of leukemia and lymphoma? If you can just tell us briefly about them.
Most common causes, right?
Of leukemia and lymphoma.
If you go through the different etiology of the leukemia and the lymphoma, the important thing is that the leukemia and the lymphoma, you know exactly the reason of the leukemia and the lymphoma, nobody knows. There is some hypothesis is that sometimes there is exposure of the drug, sometimes there is environmental toxin, sometimes there is smoking, alcoholism, that play might role. And another thing is that sometimes there is a genetic predisposition might be there. And another thing is that sometimes some congenital abnormality, some genetic disorder, they have a predisposition for developing the different kind of the leukemia. But that is not true for the each and every leukemia. In general, how the leukemia is developed, nobody know. There is a gap of the knowledge for the scientist in between the genesis of the leukemia and the exact etiology of the leukemia. So if we consider the acute leukemia per se, sometimes we see that there is a Down syndrome group of the patient, the Klinefelter, and the other immunodeficiency person, they have a more chance of developing the leukemia. Sometimes there is a chronic leukemia, particularly the chronic lymphocytic leukemia, they have a familiar predisposition. We sometimes see in the patient that the family has a leukemia, and in that family there is a chronic lymphocytic leukemia is occurring. But the majority of the cases, the leukemia occur by chance, and none of the etiology is become responsible 100% for the genesis of the leukemia. But yes, there is a radiation exposure, there is a chemotherapy that lead to the development of the leukemia in down the line. So in a single term, etiopathogenesis, etiology of the leukemia is exactly not known. Majority of the cases it is idiopathic, but in some proportion of the cases, there is a association and relations of the leukemia with some drugs, some radiation, environmental toxins, smoking, alcohol, and the familiar predisposition. Over to the organizer, please.
Right, sir. Thank you so much. Now, coming to Miss Jyotsna. Hi, ma'am. My next question is for you, ma'am. Can you hear me? Hi, can you hear me, ma'am?
I think Miss Josna is on mute.
Yeah, I think.
So we can move forward and come back to her once she unmutes herself.
Yeah, so then the next question. Can you hear me, ma'am? Uh, no, I think
Yeah,
I.
we can hear you. We can hear you.
Miss Jyotsna, are you
Yes,
there?
she's on. Yes, she's on unmute. Yes, she's unmute.
Yeah. So can you
Miss
enlighten
Josna,
us a
can
little
you hear
bit
us?
how? Yeah, I think she can hear us.
So I think we can move forward and come back to her.
Yeah, so Miss Suchita, thank you so much first of all for joining with us. And can you just talk a little bit about your journey with the disease and just through the experience?
Yeah, sure. First and foremost, thanks to Voice of Healthcare and Dr. Bhave. Um, Actually, I'm here and alive because of Dr. Bhave. He doesn't like me making it about himself. But yeah, to answer your question, I can answer it in one statement. I think your question was that how has my life changed and what. So I would say in all sincerity and honesty that it has changed for the better. It might sound as if I'm just saying it and putting up a brave front, but trust me, it has really changed, and I can explain as to how it has changed for the better. So I would say, putting it, giving a very very simple example is that right now what I do is I am looking at life as a reality show. Okay, everybody entering a reality show knows that there is going to be elimination one after the other. Some are going to be eliminated before the other. I am looking at life completely in that aspect, and because of that there is no stress. And also what I have realized it that every participant puts the best, and what you don't have control, you just don't, you just let go of everything that you don't have control over. um, having said that, also I feel what really matters is while you're in the show, right? You just enjoy the show and do the best that you can. So I look at myself as this participant who at one point felt that I have everything needed to win. You know, I was leading this very, very disciplined and fit lifestyle. I was running marathons. I was training people to run marathons. And then suddenly there was this wild card entry that came in the form of lymphoma. And, the wild card entry kind of told me that, look, I am stronger, I am more aggressive, and you need to up your game, And that's exactly how I look at life. I have upped my game in every aspect. Right now, because of that jolt that I have had, I have now a bucket list, I have goals, and I have a purpose to life. And all my actions revolve around reaching those three things, So, like if you talk about goals, they're short term goals. Recently, I had a goal I was doing, I love trekking, and I was trekking smaller. I said, no, let me do a high altitude. I went to Himachal, did a 14,600 feet altitude, and I summited. Next time I would try 18,000. Now I know, on that trek, I realized that boulders is not my strong point. I'll choose a trek which has more boulders. So basically that way. Purpose is first professional and personal. Professional is to take fitness to as many people, because I feel that I could fight this disease because of the basic fitness that I have. And I would like people to, follow that path, so that in case of a contingency, you can handle it the way I could. Personal is, of course, aging parents. I would like to look after them. So that is the purpose of life, which again gives me a, direction. Bucket list could be small, whatever gives me joy. I just do that. And I think one says that, you have to grow through what you go through. And I think I have just done that. And I'm proud of the woman that I have become. And all thanks to Dr. Bhave. I hope that answers your question.
Certainly, and in such a beautiful way. Thank you so much.
Thank you. My
Kudos to Abhay, sir. Yeah. Coming to the next set of questions. So the next question. Sorry, yeah.
I've got sound on my phone now,
No
so we
problem,
can
ma'am.
proceed. I'm so sorry.
No problem, ma'am. So can you tell us about a little bit about the support programs that your Indian Cancer Society offers for better affordability of the patients for cancer care?
Well, one of the things we've discovered is that nobody wants to support any bone marrow transplant program. So, and that includes Ayushman Bharat, by the way. So, we have now broken it up into the drugs which are given before the transplant section, and some which are given afterwards. So, some of the things that are required, like antibiotics, are hugely expensive. And so I think most people are reluctant to help in that. We try to do the best we can. We are a branch of the main Indian Cancer Society, but even in the headquarters where we run the Cancer Cure Fund, we are unable to support the cost of bone marrow transplant, which can go up from 8 lakhs to 12 lakhs. Where it is available in government hospitals like AIIMS, the costs are very much lower. And therefore, our money goes much further. We offer every patient 1 lakh per annum, which is nothing, absolutely nothing. We agree. But that is what we can afford. And we give 25,000 for diagnostics at the beginning of treatment, because that also costs a lot of money, and most patients just disappear once they hear the cost of diagnostics, never mind the cost of treatment. I found it very interesting when I could listen to the first two speakers. It's all very well to know what types of leukemias, what types of lymphomas, but we really need to figure out how can the cost of this treatment be borne, because this is really out of the reach of most patients.
Yeah,
Can I go on?
Yeah. You can also tell us a little bit about the support that probably has been provided to you by some other societies apart from Ayushman Bharat. Is there anyone who?
Yes, I believe it is the in Delhi, for residents of Delhi, it is the Delhi Arogya Kosh, which does provide some measure of help. The Prime Minister's Fund and the Chief Minister's Fund are other areas which do provide assistance. So we guide patients to go and apply over there. Uh, as I said, that in government hospitals, a lot of the care has to be provided by the patient's caregiver. So the costs are much less. As I said, in AIMS, it is 3 to 5 lakhs, as against 8 to 15 lakhs in corporate hospitals. Uh, what happens is that when a patient goes into isolation, there are costs involved in keeping that person there. In a private hospital, it can be done in an ICU. In a government hospital, there are isolation wards where the patient's caregiver is isolated together with the patient herself or himself. So the patient, in a way, is undertaking the cost of care which he or she requires through their caregivers. So it is difficult on the caregiver, but at the same time, makes all the treatment much more affordable. Now, if I can give you some of the costs that we are looking after, antibiotics for immunocompromised patients cost about 6,000 rupees per month. The SDP kits, which are blood separation kits, which can be used only once each time, cost 8,000 rupees per month. So all this is, has to be catered for. And most times patients do not understand why treatment is so expensive and why so many different tests are done. There is a psychiatric assessment test done, which is charged in private hospitals. There is a pulmonary test done. There is a neuro test done. All of these cost money and have to be catered for. So I think that some of the some attention, if I can put it that way. I know that doctors counsel their patients beautifully. I'm very appreciative of what is being done for the poorest of patients, never mind those who have all the money in the world to be counseled. But things like mouth hygiene, uh, looking after the fact of that you should not be sleeping all the time, that you should be ensuring that your oxygen concentration remains high. All of these are also very, very necessary as part of the counseling that goes on. In our branch of Indian Cancer Society, that is the Delhi branch, we have a group called Cancer Sahyog. And Cancer Sahyog is people who there are our members are all cancer survivors, not necessarily of leukemia or lymphoma, but they have been through the experience, and therefore their very presence with them, with the patients of today, is encouragement. It is hope for the future. And we have in our staff 2 persons, one who is 30 years past her bone marrow treatment, and another who is just 2 years past her treatment. And we know what a difference it has made over the years as procedures have got more streamlined. There's more human care given during these very difficult treatments, all this is as important as the money that we provide. And I hope that the doctors also recognize that fact. Thank you.
Well, truly said, ma'am. I think we all agree with you. I just want to quickly bring all our panelists, and if each one of you can just speak about the kind of support that you all have been getting or probably looking forward for the cancer funding in different states, since we all are present in different parts of the country. We can start with Dr. Kishore, sir. So if you would just
Okay.
want to say something.
Thank you, Dr. Anamika. Uh, I'm able to see. Yeah. Are you hearing me? That's great work, Josna ma'am. I think very happy to hear. Sama ma'am has been talking specifically about transplants, which I really wanted to make one small comment. Maybe I'm having the privilege of practicing in the state of Tamil Nadu, where for the last exactly, if you want to put for that, from 2002, we have a state government run program called as Chief Minister's Transplant Help Scheme, where even in the corporate hospitals, if the patient is proven on record to be of a particular financial background, the transplant is kind of taken care in entirety by the government. Not only the transplant, including a 2-year follow-up with all the medications and follow-up admissions are also taken care free of cost by the government, and there are certain rates which are fixed by the government, which will be reimbursed to the private hospital also. And from 2012 it has been kind of made compulsory for all the transplant centers to have a valid bone marrow transplant license, and the license is being given by the state government for the time being, following the ICMR and NMC guidelines, which are just coming up. Most of the centers may not be having it still now in other parts of the country. As a part and parcel of getting the license, the government also makes sure that all the hospitals which are running transplant services in the state are simultaneously enrolled in this CM scheme also. And when the right patients come in, it becomes, I can't say compulsory, it's more of a responsibility that even the corporates have to take it up free of cost and then get it reimbursed later from the government. So in one way, if I want to put, the transplant numbers in the state is quite high, especially bone marrow transplant, is just because of the mere fact that for the last 15 years or so, the government is taking care of most of the patients. And as you said, pre-transplant workups and all these things do need a lot of support from the different organizations like yours and everything, because it's like I have to submit quite a lot of documents, my clearances, you rightly put forward that to me. So all those things, I think very well the Indian societies like ICS can very well kick in to help these patients to get to that extent. Mainly I'm putting forward this in the public forum just because there may be a lot of patients who may be still unaware, even in my state I should say, because it is not something which is very widely publicized, in spite of the fact that government keeps on pushing it in frontline papers. But at the end of the day, the government scheme, and it's not necessary that something should be kind of put on to the public. So that way, it's quite a privilege, I should say. I'm very eager to hear from the rest of the panelists about their views on this.
Dr. Anamika, can I make a mention?
Yeah, Dr. Bhave, sir, if you can also speak a little about the same.
Yeah. Even in Mumbai, Maharashtra, we have lots of facilities given by the government and municipal corporation to take care of patients with malignancies. And I have to highlight Dr. Mamta Manglani's role as a pediatric hematologist. She runs a center in a place called Borivali, which is in Mumbai. And she actually runs a phenomenal transplant center where transplant is done free for thalassemia children. And it's a sensation, the kind of work she's doing along with her team. So we've got such people with us. We've got government schemes and municipal schemes which are helping us. And I'm in the private sector. So I've got some, what should I say, philanthropists who help our patients. We write out letters. I was active in Lions Club. We used to disburse funds for diagnostic purposes and for treatment. So we've got facilities, but these are very few and they don't match up, like Madam Govind said, they don't match up to the demand that is needed of doing a procedure or a transplant or a chemotherapy. In Hodgkin's lymphoma, we've actually adopted those kids. I mean, financially adopted those kids. And we've had people pay for the entire treatment. It's completely free because Hodgkin's, as you'll all know, is an extremely treatable disease. And if it's picked up early, it's curative. The intent is curative. Unfortunately, in our country, patients don't come to us in the early phase, which is why our cure rates are not very good. But if we were to pick up Hodgkin's lymphoma in its early stage, we can actually cure patients. My last point, which again is towards what Madam Govil said, that in terms of care, we concentrate a lot on the caregivers because the patient will do only as well as what the caregiver does to bring him or her to us as doctors. So if you are going to give therapy and it's chemotherapy and the patient develops neutropenia, that means drop in the white cell count, which has a high risk of infection or risk of bleeding, and the patient becomes unwell with side effects like diarrhea, vomiting, they need to be brought to the hospital for correction of that. Now, if the caregiver is not available, aware, then that patient is not going to do well, even if you've gone to the best doctor, to the best hospital. So we are only as good as what the patient or the patient's caregiver is. So we emphasize a lot on caregiving and the caregiver. So we do run, along with some trustees, something called as Myeloma Charitable Association. And in that, we've got something called as a multiple myeloma support group. And we speak to the patient and to the family members. And we tell them what is the role of the family member in order to see that patients do well. So I agree with Madam Govil that we need a concerted effect. And remember, the doctor has patients. For him or her to counsel the patients on aspects such as emotion or non-medical aspects is challenging sometimes. We would love to do it, but it's challenging because we've got patients sitting outside waiting to come in next. So there's an X amount of time a doctor can spend. So what we need are teams, which, someone does counseling, someone does psychological counseling, someone does counseling about the drugs. So we've got some people who do counseling for protocols, counseling for treatment, side effects of treatment. We need all this, and we need it in different languages. And there is an association called We Care that I've been associated with, and I'm grateful to them because they give us a lot of reading material that we can hand over to the patient. So this country needs a group of people that will work together, and several NGOs which can work together, not only for finances but also for counseling, and to see that patients who don't have caregivers are facilitated to come to the center to be taken care of. It's extremely challenging. Very easy to say it on a webinar, but very difficult to do. But if like-minded people get together, at least there can be a start somewhere, and then it can escalate into something much bigger, and that model can be copied by other places. And I'm sure it's possible to do it.
Can I come in for a moment, please? Because there's so many things that Dr. Abhay has said, which I completely agree with, and I'd just like to add something. Number one, when you talk about the Lions clubs or Rotary clubs or whoever, crowdfunding is a very important part of finding treatment costs and making them available for patients. The only thing is we need to keep that figure an ethical and realistic one. Some of the crowdfunding appeals that we have seen are really a scam. I don't think any treatment costs that much. So where is the extra money being taken off to is something that every doctor needs to look at. The other part of counseling and care, which I would like to emphasize, is to keep in mind that the patient is not an island. They have a family, and in particular, where they have young children. It is not even young children, even I think teenagers are the worst off in terms of lack of information and fear that comes to them. So if we can organize something which a teenager can reach out to, this is the Google age, this is the internet age. Maybe we should just be putting things on the internet for kids to look at, for families to look at, so that they are not so fearful about the treatment modes that go into any kind of treatment for leukemias and lymphomas. And this business of it being treated for TB is so common, and we see it when patients come to us. I appeal to the doctors. You have CMEs, continuing medical education. Please reach out to the people in the boondocks and let them know what is available. And finally, Vandana Gupta and We Care are old and very dear friends of the Indian Cancer Society, especially in Delhi. We know the wonderful work they do. We work with them. They support us. We support them in a group which is called Cancer Care India. There are about 20 organizations of care throughout India, and we would be very happy to supply you with information in your area. And I think if everybody's websites had a resource center for their area, for their city, for their state, we could really work wonders together. Thanks again.
Absolutely. Thank you, ma'am. That's absolutely rightly said. I would just like to pitch in an extension of what Dr. Bhave sir said. So I think we all have worked in government and corporate setups both. And like when I was doing my residency program, the DM residency program at AIMS, I would just like to mention that though, yeah, I completely agree that Ayushman Bharat does not support transplant, and that is an unfortunate truth. But there, especially in cases like pediatric acute lymphoblastic leukemia, especially pediatric patients, and patients like Hodgkin's lymphoma, as sir correctly mentioned, that it has a wonderful outcome. So those patients are they get tremendous support because the kind of packages that there can be different packages. Maybe in Maharashtra there are different packages, and maybe in Delhi and Ayushman Bharat there are different packages. But as a resident working there, I realized that there are so many children which do genuinely get benefited under these programs, because these packages cover almost like lakhs and almost 1.5 months of treatment, which includes their intermittent supportive care for febrile neutropenia and HDP and whatever blood transfusion. So yeah, I mean, though I know that they don't support transplant, and in future we can hope for it, but yeah, they are a good initiative. And also, Dr. Amrita, I would like to know about what you feel as a doctor working in a corporate sector. What do you feel? What are the challenges that we face as far as this is concerned?
I
Can you
think
please
other people who work in the private sector would kind of agree with me. All this CM Relief Fund, PM Relief Fund, which I've seen patients have access to when I was in AIMS. I mean, unfortunately, we have poor patients visiting private hospitals, and unfortunately, the cost of a transplant or cost of hematological disorders, treatment of hematological disorders in general, chemotherapy, the supportive care, tends to be beyond the reach of even, I would say, the lower middle class. I think only the upper middle class and people with money or an insurance or some kind of money backup or financial backup are the ones who actually are able to go through with the complete treatment in a very in a less hassled way. Otherwise, it's all about arranging money, going through the treatment, support. It becomes really tough because treatment of hematological disorders per se is expensive. And in the private sector, unfortunately, we do not have any support from any of the relief funds. So most of the times it is because it is only for people who have an insurance or people pay out of the pocket. And we do have really deserving people who are unable to afford treatment. So I feel the private sector is kind of ignored. We do not have access to all this help from the government. In a government setup, we do have access to all this help. I think if we could make it more equal, we do good work in the private sector. We also have a good chunk. We contribute to the medical care of a good chunk of the population. So I think these relief funds should be accessible to people who are working in the private sector, because I don't think government hospitals can bear the entire medical care of, the population of India. So I think we should have access to finances from the government, even in the private sector. People talk about, scams and unscrupulous practice happening in private sector. There is a lot of good work. There is some unscrupulous work also going on. But I think, just like we say, innocent until proven guilty, I think that should be the concept even in medical care. I think finances should be made available to the private sector so that we can offer these life-saving treatments to many of our patients.
So can I just say, Amrita, I agree with the fact that, I also work in the private sector and I really understand what you're saying, because many times we have patients who cannot afford the private sector, but also cannot handle the waiting time or the crowds in our government and municipal institutions. And let me tell you, our government and municipal institutions are doing a phenomenal job, given the fact, the kind of workload they have and the kind of funding they have for themselves. They're doing a great job, but there's an X amount they can do. It is these fence sitters who tend to come to us in the private sector with not much money, but with a lot of desire to do well. And that's where we are emotionally also very challenged at that point, because we can see in front of us a patient who's going to do well, but cannot do because of financial reasons. So I fully take your point, and I fully understand what you feel in the private sector, because I'm in a similar situation. But then we look to our philanthropists, we look to our friends, we look to um, out of the pocket. I've also taken care of patients, because that they're going to do well, and we write off our charges for so many patients, because we know that this is a deserving patient, especially when it comes to Hodgkin's lymphoma, acute promyelocytic leukemia, to hairy cell leukemia. They are worth treating. They are worth not taking a charge for, because they're going to do well.
One small comment, Alonso. I mean, what I said is absolutely right. The moment the bigger hospitals started moving away from being run by doctors to the hardcore professionals, so even if I want to do, unfortunately, yes, there is a system that Amrita, CGHS and ECHS can very well be enrolled, and a good number of patients who are in that can come in. But we know what we face, and our administrators are like, uh, so that's like something which the government also has to work on. We can't comment on it on a public forum. So they have to revise rates. It's at 1995 rates which are still going on. So naturally, nowhere to blame. It's a combined responsibility which needs to be taken care of. I think it is coming up in a big time.
I truly agree with all three of you. So yeah, moving on. My next question is directed to Dr. Bhave, sir. So we've already spoken about the risk factors, but can you just elaborate a little bit about if there are any modifiable risk factors? Would you want to speak about it just as a one-liner? So you are on mute.
I'm just saying that I don't think anyone is at fault for getting a disease like a malignancy. No one wants to bring it upon himself or herself. I don't think they are guilty. But if someone is chewing pan or tobacco and keeping it in the mouth and gets a local cancer, someone has large amounts of alcohol or smokes and gets a related malignancy, that's a different matter. But you'll see most of these hematological malignancies may not necessarily, as Dr. 𝗪𝗠𝗏𝗏𝗏 already mentioned, that there are some modifiable risk factors. Maybe radiation, prior radiation exposure, prior some chemical exposure, people who have been exposed to some solvents, dyes, chemicals, people who have got underlying autoimmune diseases. There might be a family history, so therefore there might be genetic reasons. Nowadays, I don't know if you know, but there is a entity called a breast transplant related lymphoma. So there are different things, risk factors which are available, but most of the times it is not the fault of the patient. So I keep telling the patient, please don't feel guilty. It's not your fault. You didn't get this onto yourself, because they feel very guilty that they got the cancer, no one else. So we try to explain to them, this is not your fault. There's something called a cell of origin. That means there is a starting point for a cancer to happen, and that's a cell. When that cell goes rogue because of a change in this gene sequence, then that becomes from 1 to 2, 2 to 4, 4 to 8 exponential growth. Now, all of us who are on this webinar, sitting, standing, and doing whatever, we are at risk for getting cancer. But many of us don't get it. And the reason is because we've got a tumor surveillance inside our body, which is constantly detecting any changes in our cells. Any cancerous cells comes up, it picks it up and eliminates it. When we lose that surveillance is when cancer develops. So why do we lose that surveillance? My answer is GOK. God only knows. But there are some things. There are some things like radiation exposure, chemical exposure, tobacco smoking and all cause an unhealthy environment that might give a chance for these genes to express themselves and manifest themselves and become a malignancy. So if you have to ask me what are the risk factors, there aren't actually any. The fact that we are alive, breathing, walking, we are at risk for cancer. And I can't modify my life. I can only modify certain factors like, alcohol, tobacco, smoking. And there are so many people who are doing that and they don't get cancer. So honestly, on this forum, I can't answer that question. We just hope that we don't get it. And if we do get it, we are fit enough to be able to handle the treatment of it. And we've got enough finances to be able to make a proper diagnosis and take treatment. That's all I can say.
Right, sir. Truly said. So it's an extension. My next question is also an extension of what Dr. Bhave sir said. For Dr. Kishore sir, so since as sir said, are there any screening tests that most of the patients do ask in the OPD? What did we miss out on any tests that we should have done prior to why did we get this disease? So can you just tell our audience about it?
Bhave sir has very beautifully put forward what to expect and what to answer for this question. Unfortunately, lines like breast tumors or cervical tumors, they do have a set screening methodology to do. But one part of the blood-related cancers is also the presentation is also not dramatic sometimes. Like say we have 3 cells, hemoglobin goes down. I feel a bit tired, and platelets, unless they're very low, less than say 20% of what is normal, I may not bleed, and unless otherwise my WBCs are less than 30-40% of what is normal, I may not show signs of infection. So that's the reason. If you ask me, am I tired now? Yes, I am tired now. So it doesn't mean that I have to go and check myself for a blood-related cancer. So this is a very vague kind of a symptom set what we have in leukemias and lymphomas. That itself is an issue sometimes to pick up these conditions early. So screening wise, if you really ask me, Tufan sir also has very clearly pointed out there are certain specific set of individuals like who have got a family history. That is also very rare in blood related cancers running in the family, but still theoretically they can. And sometimes children with some genetic abnormalities who have a tendency at a later date to develop blood related cancers. In them, yes, we do put them on a very tight kind of monitoring, and many times it is like on a regular master health checkup, which most a good number have started doing off late. It's like whenever somebody comes in for a master health checkup, it's a very common practice I see in our Indian patients, that it's not that they want to get tested that everything is right or wrong. There'll be something wrong in them, but they want, as a puzzle, they want the doctor to find it out. So that's the reason they come over. So as a part and parcel of every master health checkup across India, I should say CBC is a very simple test which is being a part and parcel of it, which will pick up many a times these kind of very early stage cancers, especially cancers like myelomas and a particular type of lymphoma called a CLL, where the cancers may be in a very picked up in a very very initial stage and they may not need any treatment. So those cases we try to put them on a kind of a follow up regularly, just to make sure to act immediately when that particular patient is going to need a treatment. Apart from it, a specific set of screening for a general population is very tough to say. But one thing I want to point out in a public forum is more than the patients with themselves, it's a common practice that is very rare. We see these patients walking into a Hemato-Oncology OPD or oncology OPD straight away. Their first point of contact is many times the general physicians, the pediatricians, the people who are at the grassroots level. And I think it's more and more important to make them aware and make them, unless their brain is going to know, the eyes are not going to see. So make them more aware. So with talks or whatever about the test and the, to be more frank, there is still a myth among the say as general practitioners, as blood cancers are quite what to say, like that's like the last bill that has been written on your thing. It's not like the things have changed a lot. When I started my practice 15 years back to now, I'm seeing much changes. So I have people who, what to say, like they highly said that why are you going into a field of hemato-oncology where the prognosis is not that great. But I can look back and say after a decade of practice that things have really really changed. So this has to go to the primary level physician, so that they become much more what to say, like vigilant on picking up this type of, because lymph node anemia, everything is first seen by a local physician, and then only he or she gets into a doctor house kind of a pattern, and then picks up and refers at the right time to the right doctor. So that's more important. I should say screening starts at their level, and they should be well informed about it. Thank you, Anamika.
Absolutely, sir. True. Also, I would like to mention, since most of us are from the corporate sector, and since I think we get most of us are seeing cross references from different departments, and that's how we most of us have picked up so many multiple myelomas or so many other leukemias. So that is also a key. If other super specialities are even briefly aware about our branch like hemato-oncology, that also plays a very important role, including obviously the diagnostics that you mentioned. So yeah, so coming to my next question is for Dr. Amrita ma'am. So ma'am, mostly people want to know that whether all leukemias and lymphomas require treatment, and if yes, then can you just talk a little bit about it?
Um, so even in blood cancers, I do think we have some good blood cancers, is what I would say. So broadly speaking, leukemias can be categorized into acute leukemias and chronic leukemias. Acute leukemias are the ones that are immediately life threatening, and most or all acute leukemias, they need treatment immediately. Coming to the chronic leukemias, we have basically two major categories. We have that arising in the lymphoid compartment, which we call chronic lymphocytic leukemia. And we have the other category, which is chronic myeloid leukemia. So chronic myeloid leukemia generally needs treatment, initiation of treatment as soon as a diagnosis is made. In chronic lymphocytic leukemia, to be really specific, there can be a period of wait and watch until the patient becomes symptomatic, or until the patient starts impacting the body, and until the disease starts impacting the body. And then you can kind of initiate treatment when certain criteria are met, when certain clinical criteria are met, and when the patient becomes symptomatic. So to be very precise and to be very to the point, I would say all acute leukemias need treatment immediately, because there is an immediate threat to life. Amongst the chronic leukemias, generally there is no immediate threat to life, is what I would say. A chronic myeloid leukemia needs initiation of treatment immediately. We initiate treatment for CML or chronic myeloid leukemia immediately, whereas in chronic lymphocytic leukemia is one of those better diseases, or I would say, the better diseases usually diagnosed in the elderly, where many of the elderly patients, they may not even need treatment during their life. So I think that is all that I have to say. Chronic lymphocytic leukemia is one of those one of those cancers which does not immediately need treatment. The rest of them usually do. Just like chronic lymphocytic leukemia, you can have certain indolent lymphomas like follicular lymphoma, which sometimes may have a period of wait and watch before you actually initiate treatment.
Anamika, can I make a comment?
Sure, sir. Please go ahead. Thank you, ma'am. That
Dr.
was very quick and informative.
Yeah.
Thank you. Yes, sir. Please go ahead.
Dr. Amrita put it so well, man. One of the challenges I face is in diagnosing this condition called CLL, and another condition called MGUS, monoclonal gammopathy of uncertain significance, which is like a precursor to developing another cancer called myeloma. And here we diagnose because we have screened and we have done tests, and we tell them you got cancer, but you don't need treatment. Now, this is one of the hardest situations that I face in my practice, where I tell a patient you've got a cancer, but I'm not going to treat. And the patient is looking at me and saying, but you're a hematologist, your job is to treat. So why are you not treating me after diagnosing me to have cancer? So sometimes I just wonder, early diagnosis of CLL, should I do it or not? Because every day morning, this patient, and the CLL is going to go on for months to years without any change. But every day morning when the patient gets up, he or she feels, now what's going to happen to me today because I've got cancer. So sometimes, we are in very difficult positions to make a diagnosis. And like Dr. Amrita said, that there are some good cancers and bad cancers. Beautiful. All cancers are not bad. They're highly treatable also. And just like Dr. Kishore said, that we've got such fantastic success stories, and one of them is sitting over here with you, doing so well. But sometimes making a diagnosis is also a problem. Early diagnosis is great. We say prevention is better than cure, but once we make the diagnosis, sometimes we don't know what to do with it. So, it's nice, but sometimes we are in a tricky situation.
I kind of explain it to them that, just like diabetes, initially we can, get away without any medications with a bit of lifestyle modification. I kind of tell them this is a pre symptomatic stage. And the best thing that we can do right now is wait and watch, and that you may not even need treatment for a long, long time.
Thank you, both of you. Coming to 𝗟𝗘𝗨 ma'am, my question is, what do you think about the patient advocacy groups? You think they should be established, and you think they will benefit patients in the long run?
I think every one of you have said yes, that you do need, you don't have time as doctors to start looking at the emotions of patients or to address their fears, their misconceptions. So most definitely you need patient advocacy groups. We need patient support groups. Yes, definitely. Your advocacy groups can address things like proper data. They can address things like lowering the cost of drugs. What should be the level of GST on those drugs? And your support groups can just hold a patient's hand. In fact, talk to the very patients that Dr. Amrita and Dr. Bhave have talked about, that you have cancer, but we are not going to start treatment. So if they need to unload on somebody, let it be some people like us, rather than coming back to you over and over again in your overworked surgeries. Would you agree?
Yeah, absolutely. Anamika, can I make a comment? Because
We all agree.
this is fantastic discussion. So, Madam Govil, cut to the chase. We have treated patients and they have become well. Now, consider these young kids of Hodgkin's lymphoma or acute leukemia who are now, in inverted commas, remission, or even for that matter, cured. We have no group that takes care of their the matrimony. These are young
No,
kids.
that's not
What?
so, Dr. Bhave. In Bombay itself, Indian Cancer Society has a group called UGAM, and I know that they have done very successful matrimonial counseling and so on. Sometimes, only sometimes, we get queries of this type. So my son wants to marry this girl and she has had cancer. So what should we do? Now, I'll just give you an example of a young woman who was diagnosed with acute, I forget what, leukemia, and had very little time to live. Her boyfriend married her in the ICU. She didn't live for long. She lived perhaps for another 15 days or 3 weeks after that. But she died happy. And that young man has gone on subsequently to marry and raise a family. I think we need more people like that. People who understand that there is a person behind the disease. It's not just a leukemia, not just a breast cancer, not just a sarcoma. There is a person there who is living, breathing, emoting. And that is what we require. Yes, we need more groups like that who will take on matrimony and much else, much else.
I think Preeti is part of UGAM, if I'm not mistaken.
Oh, Preeti, I didn't see you there. Hi.
No. I'm saying that Preeti is part of UGAM and she's an active member of UGAM. I know her. But in the private sector, we still are asked questions. Will this disease come back? Should my daughter or son marry this person who's got leukemia? It's very difficult, and we need someone who will, make these people come together and talk to them.
Doctor, get your cured patients to form support groups for you.
I tried
It's
that
not
with
enough to have one or two groups. You need
I
a
did
group
that
with every doctor. Yeah.
I've tried that with 3 NGOs, and it's not working. We've tried making a matrimonial page also, but it's not working. So I would love to get together with your team, and because these kids need a chance to get back to life. What's the point in treating them
Absolutely.
and then not giving them the things that they deserve in their life, such as
Correct.
love, marriage, etc. They are not getting that. So we are not doing it completely.
Get a support group going, and even if one person talks about the fact that they have found love and marriage in that group, it will encourage others. You're saying it doesn't work. It doesn't work. Neither did treatment for leukemia work 50 years ago. It's working today. I think I've been alive long enough to see the changes, and I really feel don't give up.
So yeah, don't give up is the motto. So we're just coming to the end of our session, and we all would love to hear from Miss Suchita. You also want to share something more about the experience. You've already beautifully shared your story. So what are the challenges that you had to overcome, or just anything that you want to speak about?
I think Miss Suchita,
Suchita,
you are on mute.
Sorry. Okay,
Yeah.
so the nature of the disease is such that there are going to be challenges, small and big. I don't want to, make it sound as if it was one roller coaster. I mean, it was one hunky dory ride. There were this, but I think I was lucky after hearing all this conversation today. I felt that because I am from Mumbai, it got diagnosed in the first 1/2 stage. I had a beautiful doctor like Dr. Bhave. He keeps saying that he's busy, but trust me, there was transparency. He was patient. He was all my questions, my husband used to say, how many questions you're asking, but Dr. Abhay used to respond. So I was lucky in that sense. Having said that, there were still challenges. The simple ones I won't get into, because one is that you start off with why me, then you have to overcome that. And I had resistance towards if you know that there's these rounds going on Facebook, where they say that be compassionate towards chemo people who have had chemo, because their life is never going to be the same, and you're subjected to all these negativity. So I was very resistant, and Dr. Bhave made it very clear that come to me with a positive bent of mind, otherwise I'm not treating you. So very early on, I was, the importance of mental setup was kind of drilled into my head, and that is why I conditioned my mind to be positive. Now these were the easier ones, I guess. Worried about parents, how to balance with professional life with my chemotherapy, with the treatment. All those were the easier part. The difficult part of my journey were two instances which Dr. Bhave, of course, was a part of. One was that in the second round of chemo, the second drug that was introduced, my body didn't accept it, and I had to go into ICU, the rituximab, Dr. Abhay, if you remember. So that was a challenge, because I had complete faith in God, in doctor, in myself, that I would fight. But those 28 days, I was so worried, because Dr. Bhave said that this is a drug that too good a drug for your body not to accept, and I knew that he would do everything to make my body accept it. But I used things like manifestation, positive affirmations. I have diaries even now, which I wrote rituximab. My body accepts rituximab. I used to write it down. It might sound stupid to medicos, but I used to think, if it's not going to harm me, let me do it. And I used to do all this. So I used positive affirmations, I used visualization, all of that. Then the second challenge came after my fourth chemo, when I had a catheter related thrombosis. So my superior vena cava was blocked. Again, Dr. Abhay Bhave handheld us at that that time so beautifully. I had to do a peripheral plasty, I think it is called, I may be wrong. So yeah, removing of that blockage, which was unnecessary. But yeah, these challenges were there. But if you have your faith in place, and if you are, I think, and you have your family, as Miss Jyotsna said, that patient is not an island. So when you have your support system in place, my family was rock solid support. Doctor, I can't talk enough about that. Dr. Bhave's assistant, Dr. Nawal, all of this. And then I had 4 or 5 trainees who were doctors. So whenever I didn't want to trouble Dr. Bhave with silly questions, these people were my support group who used to, I think one of them spoke to Dr. Bhave, and Dr. Bhave told him in medical language. He explained to me in layman's language. So yeah, I've been lucky, but yes, there will be a struggle. You have to just dig deep. I used to tell my trainees, while running on the slopes, that when the going gets tough, the tough get going. And this disease actually made me use that as a principle, not of running, but principle in life. And I think, it is gone. It's been smooth sailing. And as I said, at the end of the day, it's all hunky dory.
So yeah, that was really beautifully explained. Thank you so much.
Welcome. My pleasure. I just want everybody to be positive and fight. And, it's never over till it is over. It's just a bend, not an end. Just fight and come out of it, That's what I would say.
Well spoken.
Yeah. So yeah, thank you all of you for taking out time. And it was a lovely, emotional and an enchanting session. So thank you all of you. Thank you. So we'll just like to wrap up the session. If you have any few last words, we just have quick last 2 minutes.
I think we have spoken enough, and we really want to win.
All of you have been really wonderful. Thank you.
Yeah, we want to win. We want to win. Just let people come early to us, please. We can do so much when people come early.
Yeah.
When they come late,
yeah.
when they come late, we can't do anything much. Yeah. But it's early diagnosis that is the key.
Absolutely. Yeah. So thank you so much. Yeah. Thank you. Thank you for the lovely session.
Bye-bye.
Bye.